This is a presentation that I recently gave as the annual visiting professor at the University of Pittsburgh Medical Center in the honor of Dr. Freddie Fu. This gives me the opportunity to honor my good friend and first partner, Freddie Fu, who unfortunately passed away, but was an incredible influence in my life. I think this will be of interest to many of you who are surgeons or non-surgeons if the idea of innovating is something that you're interested in. So the title of this presentation is Innovation in Orthopedics and Shoulder Care, which is what I do. And I'm going to present this in the context of culture and creativity with some business background, some financial ideas, and like most innovations, it doesn't follow a straight line. It's going to be a bit complicated. I recommend you watch this in two viewings because there's a lot of information here, and one viewing probably will be a bit too much. This presentation is loosely based on a book written by Clayton Christensen, and I'll talk about this a bit more. And the book is entitled, Who Has the DNA to Innovate? And the question is, are people born as innovators or are they made? My qualifications are somewhat limited, but nonetheless, I've been in practice as an orthopedic surgeon for many years. I've had a lot of experience in startup companies, and I'll talk a little bit about that, but mostly I'm going to talk about the idea of innovation and innovation that creates value, not necessarily financial value. I've also was lucky enough to attend Harvard Business School, and I'll talk about that a bit. Now, innovation happens here, as you see in blue, is on the home page of the place where I work, which is a Mass General Brigham. Let's consider this in the following talk. My faculty disclosures are here. The flags represent the different countries in which I work. I'm not going to talk about specific products. Uh, I have been involved in a number of different ventures. The ones I'm most interested to talk to you about are Boston Shoulder Institute and the Codman Shoulder Society, neither of which have any kind of financial connection to them, but which create value, I think, for patients and for physicians. I started practice in 1990, and the first place I worked was University of Pittsburgh Medical Center. And for the 8 years that I was there, it was akin to kind of a Camelot. I had the opportunity to learn about research and to be inspired by a variety of individuals, not only Freddie, as you see here, in a typical pose for Freddie, confident and quite charismatic, but also with many of my former fellows and students. This is a grainy picture from 1994, predating digital photos. And in this photo, you can see Freddie Fu and myself, and many of our former fellows, including Paul Chang, who is a well-known sports medicine physician in Singapore, Mehmet Demran, who's in Turkey and was the president of the European Society for Shoulder and Elbow, Andreas Imhoff, who worked in Germany and was extremely influential and capable as an arthroscopic surgeon and reconstructive shoulder surgeon. And then John Ticker, who was my first fellow to gain entrance into the American Shoulder and Elbow Surgeons. And of course, Chris Harner, who was our partner back then. So let's consider your journey, and I'll share with you my journey. So I was born on a SAC Air Force Base, Shepherd Air Force Base in Texas. And then my parents moved to New York, and I grew up in a upper middle class place called Scarsdale. And I went to school in upstate New York called Colgate, and I had a relatively undistinguished career at this point. And then I went to University of Rochester, where I had my first mentor. That was McAllister Evarts, who was really a legend at his time. He was one of the first people to do joint replacement. And in those days, a phone call made all the difference. And Mac Evarts made a phone call to Henry Mencken, which got me into my Harvard orthopedic residency. I then went to Europe, and I'll come back to that in a moment. And then when I came back, I was lucky enough to have a fellowship at Hospital for Special Surgery and Shoulder and Sports Medicine. And I met Russ Warren, who was a mentor of sorts. He was a hard taskmaster, but an incredible innovator because he was always asking questions. That's very important. I'll come back to that. But most importantly, when I finally moved to Pittsburgh, because Freddie Fu walked into the lab one day at a Hospital for Special Surgery and asked me would I be interested to go there, that changed my life because Freddie was an expert in influencing people in a positive way and scaling them to be better versions of themselves. And in this regard, he was quite a charismatic character and an incredible influence on many individuals. After this, I met Jim Herndon in Pittsburgh, and he invited me to come to Boston, which I've been now for some time. I'll talk about that a little bit more. Now, when I was in Europe in 1988, I had the opportunity to explore and make new friends, which is really a key part of becoming an innovator. One of the most important people in my life was Christian Gerber, who I met when he was just a so-called chief resident, what they called an Oberarzt. And I had the opportunity, because of meeting him, to go to the University of Paris and do research, and then to spend time with Jan Gillqvist in Linköping, Sweden, at his university. But what I want to make sure I mention here is that I've learned more from my students probably than I've learned from my so-called mentors. And after 34 years of fellows, just take a look at this incredible list of individuals. Lower left, you see Brian Cole. Almost everybody knows him who knows about sports medicine and shoulder. Over here was my host at University of Pittsburgh when I gave my grand rounds. Right next to him is Larry Higgins. Below is John Ticker, who was the first fellow I had who got into the Shoulder Elbow Society. Here's a young Bassem El-Hassan, and many, many more. Every one of these individuals is an expert and achieved remarkable success. Just like E. Emery Codman, who I'll talk about a little more in this presentation, I realized it was the approval of my students rather than my peers, which was of the greatest value. And that's I've passed into the stage now where I think more about legacy than resume. And every single one of these individuals represent a legacy for me. The other bit of advice I would give you is that it's partnership that makes you better than who you are alone. I've had incredible partners. Just look here: Peter Millett, Matt Provencher, Larry Higgins, Bassem El-Hassan. I wonder how many of you have had that kind of opportunity. And I could talk for an hour about each of them and about what they've meant to me and how much they've helped me become a better version of myself when it comes to thinking about questions and solving problems. But let me get back to the question of innovation. And two people that have been extremely influential are Albert Einstein and Michael Porter. Albert Einstein, you all know, he said, if I had an hour to solve a problem, I'd spend 55 minutes thinking about the problem and 5 minutes thinking about the solutions. It's really important because the questions are usually more important than the answers. And Michael Porter, who was my mentor at Harvard Business School and just a force of nature, he said the essence of strategy is choosing what not to do. We have so many demands on our time. We can't think with critical clarity unless we identify what we don't want to do. Now, this is an image I had taken from a meeting I went to in Rome. And I use it to show that really the world is full of innovators, but not all these people innovate in the same way or at the same level. And we'll talk about that a bit because many people innovate every day, but few people innovate in a way that makes transformational change to what you and I do every day. Well, it's not a bad idea to start with some history. How many of you know that E. Emery Codman, who was well known for his work in shoulder, also wrote a book on the study of hospital efficiency? And 100 years later, Michael Porter wrote about redefining healthcare. It was really Codman who started the idea of value with his end result concept. And this was a cartoon that he drew that I put the word value on it. And this question of value in healthcare, which of course has been something we've been trying to innovate, has been ongoing for 100 years. I can't get to the question of innovation unless I talk about some economics. This is Michael Porter and I in front of a mural of Codman on the wall outside my office when I worked at Mass General Hospital. And in summary, this is kind of what I learned from what he taught me. Essential to the question of value is measuring. Why do you measure? You measure to improve what you do. You measure to bend the experience curve so that your learning curve is not problematic for your patients. You measure to be profitable, to think about the bottom line, that is margin, not revenue. You measure to align with other stakeholders, to risk stratify, to reduce unnecessary care, to integrate care and manage resources, which is one of the greatest elements of innovation, and to learn from others' examples of innovation. So here's the Mass General Hospital. This was taken some time ago. It's now even bigger through what's ongoing. And frankly, Mass General Brigham is in the process of merging, creating a Brigham and the Mass General and affiliated hospitals into one entity. In this giant center, I worked here in the corner office, and I did that for about 25 years. While I was there, I went to Harvard Business School. I founded the New England Shoulder Elbow Society, the Boston Shoulder Institute, and the Codman Shoulder Society. I'll talk a little bit about these later. And then one of the greatest things I did was hire my current partner, Bassem El, to take over for me. And he'll show up a little bit more in this lecture soon because he's a perfect example of someone who innovates every day in the operating room. I now work at our outpatient surgery center about 10 minutes from my home, which gives me more free time to think about innovating. The arrow on the bottom here pointing up is where my office is, and just above, a floor above us, is the outpatient surgery center. And because of the innovation of outpatient surgery and the anesthesia possibilities we have, we do many of the cases that we used to do in an inpatient setting, in an outpatient setting, and that's a form of innovation that has dramatically reduced cost and thus improved value. Well, it was Clayton Christensen, one of the professors at Harvard Business School, who said, um, who asked the question actually, will disruptive innovation cure healthcare? And he's contributed a huge amount. Unfortunately, I had never had him as a professor, but I recommend you look him up and read some of what he's written. And you'll find much of this on the Codman Shoulder Society, which I'll get to at the end of this talk. Regina Hersinger was one of my professors, and she wrote an article in Harvard Business Review entitled Why Innovation in Healthcare is So Hard. And we have to remember that as a business, healthcare is extremely complicated compared to other sectors. She wrote this great book on who killed healthcare that looks at the delivery of healthcare in different environments, different cultures, different countries. Michael Porter partnered with Robert Kaplan, one of the giants of accounting, to marry strategy and finance to try to solve the cost crisis in healthcare. It's been very influential, but unfortunately, we still have a cost crisis in healthcare. And Harvard Business Review wrote this, which I think is really important to any of you who decide you want to innovate. This article says the happiest people pursue the most difficult problems. And if you try to innovate in healthcare, you're definitely pursuing a difficult problem. Well, my first step in getting involved in trying to innovate was going to this course on value-based healthcare in 2012, taught by Michael Porter. And this was really, for me, transformational. Here I am here right before Michael Porter, and most of the people in this picture are physicians from all over the world. And then several years later, in 2015, I went to a course taught by Regina Hertzlinger, who's in the front row here with the sunglasses on, entitled Business Innovations in Global Healthcare. And here I am here, and most of these individuals are in venture capital. And finally, I took the dive into an executive program at Harvard Business School. That's their version of an executive MBA. And here I am here, and 55% of my class were from all over the world. They were international. And my interest was to understand other business sectors, be it fintech or retail or banking or a variety of other areas, so that I could see how business worked outside of healthcare in order to determine what from that I could take back into healthcare. Now, let's consider some economics. If you look at the public and private per capita health expenditures in a variety of countries in 2022, you'll see that the United States is at the top of the list. And most of the spending is public. That's not really surprising. Look at the next closest competitor or next closest country, Germany, and you'll realize that we spend more than anyone else. But as you'll see in a moment, we don't necessarily get value for it. In fact, this is somewhat old from 2014, but even then, the US was spending 17.8% of its GDP on healthcare, more than any other country in the world. And the next closest country, which was Sweden, the US spent 44% more than that country. Where does our tax dollar go? Our tax dollar is broken up here, and this is somewhat old data that was given to me by Dr. Higgins, but nonetheless, it's patterned for the cost that we apply to different areas. And it was 23%. It's different now, of course. And the next most expensive area was Social Security, and you can see that defense is here at 19%. And to be fair, defense is rising, and probably healthcare is going to be going down because of the current state of affairs in the world. Well, for a moment, let's look at an economic engine. And for comparison, let's look at Mayo Clinic and Mass General Brigham, which are similar in size and certainly in stature. If we look at the second quarter of this year, the operating revenue at each institution was $5 billion, but the operating margin was 6% at Mayo Clinic and 0.6% at Mass General Brigham. Now, I could go into detail about why this is, but it has a lot to do with the culture of these organizations, the context, that is the place where they are, and their overall mission, relative to where they are. Social media can be very useful too. And Eric Bricker is just a wonderful explainer of healthcare. And in one of his posts on LinkedIn, he wrote about who has the power in hospital systems to influence. And frankly, he identified that the top players from the standpoint of economic impact are orthopedic surgeons, followed by neurosurgeons, particularly spine surgeons, cardiologists and CT surgeons, and oncologists. And the reason that they're so influential is that each of these has high margin services with a favorable payer mix. That's just the reality. They drive the hospital's bottom line, top line and bottom line, actually. So I looked at 1 month of surgical cases at the Mass General Hospital, both in the inpatient and outpatient. That was in 2018. And I did this as part of my work at Harvard Business School. And if you look here at this graph, you'll see the different services. But the bottom line here is that when you combine outpatient and inpatient, orthopedics represented 26% of all of the volume of surgery at our organization. So that fits very much with what Eric Bricker says about these things. But let's look for a minute at the overall spend in orthopedics. The entire orthopedic industry is described in this annual report from Ortho World. And I wonder if you knew the number for the spend in 2023. It was slightly over $57 billion, and the annual growth rate year over year is about 3.5%. Well, let's take this apart and consider what, if we're orthopedic surgeons, what we do. The leading driver of costs, actually of the spend in healthcare, is joint replacement globally, and that's a little over $20 billion. Now, if you look for shoulder, which is what I do, you won't find it here. It's blended into other areas, be they sports medicine and extremities. And frankly, extremities represents almost $3 billion. So a relatively small component of the overall spend. If we look at enabling technology, which includes things that are becoming quite popular now, like robotics and artificial intelligence and navigation and things of that nature, it's only about 2.1% of the entire spend globally in orthopedic care. Why is this relevant? Well, context is important. Now, this is old data. This goes to 2009, but it's even more the case now. Look at this pattern. If you're like me and you work in an academic medical center, or for that matter, in most medical centers, you can see here that the percent growth of the US healthcare spending per capita is the black line. The spend on the administrative burden in these institutions is the yellow uh, uh, area of this curve. And then the spend on physicians is the maroon area. So there's something out of whack here. This seems upside down, doesn't it? In fact, if we look at income growth overall, this is demonstrated as well that the spend for administrators is significantly greater than for physicians in terms of overall percent growth. This is quite important because it affects the culture in which we work and probably our capacity to innovate. That's just speculation, but we'll come to that in a minute. Now, hospitals also have to deal with the reality of a diminishing margin, and this is an example of what's happened with hip replacement, for example. In 1997, as a percentage of the overall cost of the episode of care on the day of surgery, actually for the episode in the hospital, the cost of the implant was 29% of the overall cost of care. And in 2005, it was 61%. And depending on what kind of implant you're putting in, if it's shoulder or hip or ankle replacement, that margin contribution is, the cost is significantly increased and the margin significantly diminished. So how do we compare globally from the standpoint of how patients see us and then particularly trust? So this is a graph, and if you look at this graph, you can see that Switzerland is #1 when it comes to trust and also satisfaction with treatment. Here's the United States at number 24 in terms of trust, even though we're #3 in terms of satisfaction with treatment. So we're doing something wrong, and the return on investment in terms of the patient's experience is really problematic. Here's another important bit of data. If we look at evidence based as a basis for care, and this is an article from the New England Journal of Medicine in 2003, you can see here that at the top of the list is coronary artery disease. That means that coronary artery disease is delivered based on firm and strong evidence 68% of the time. But 45% of patients don't receive care in accordance with the best practices when you look across all these different care delivery areas. And you won't find orthopedics and shoulder surgery in any of this. So Mobandari wrote this great book on evidence-based medicine. And frankly, if you look at the hierarchy of evidence, you can see here that as we go to the bottom, there's a great deal of bias. There's certainly more bias based on opinion. And as you go towards the top, to prospective randomized study, there's less bias. There are still problems with the evidence we use. Most of the evidence that we use as surgeons to make decisions and to look at the value of what we do is level 5, level 4, maybe level 3, sometimes level 2, but rarely level 1. And it was Ioannidis who wrote an article about all of what I'm showing you here. And the title of the article is Why Most Published Research Findings Are False. And the reason is that you'll find exactly the same study disproving a study exactly like the one that it is doing because of the quality of the research and the fragility of the study and a whole bunch of other factors. Yet we still use literature, studies we read, as a basis for what we do. So let's pivot to value. This was a image given to me by Larry Higgins some time ago, and it's still appropriate today, but it's modified a bit. So if we look at value, it's personal. So if we consider value as outcome divided by cost, the patient wants an outcome. That's all the patient wants, and usually they're not paying directly. A third party's paying. They may pay copay and have deductibles. The government wants control. Insurers and hospitals, they want to manage cost, they want to manage time, they want to manage resources. The surgeon definitely wants an outcome that's good for the patient, but also wants an income. And when you consider all these factors, it's true. You open the fortune cookie, it wasn't chicken that you had. I know this personally because in 1984, when I had my second shoulder surgery, you can see the standard of care at that time after an open capsular shift was a half-body spica cast. Now, even Charlie Neer, who I'll talk about soon in this talk as one of the great innovators, was wrong sometimes. And I can tell you from a personal point of view, it was wrong to put somebody in a spica cast after a capsular shift. The reality is the current problem, or at least the root cause of our problem now, is a lack of alignment. And this is a multi-directional tug of war. So let's look at all the different stakeholders here. Again, all the patient wants is an outcome, and he wants it to be durable. If you're the doctor, you still want a good outcome and you want a good income. If you're the hospital, you want increased access to have volume so you can manage your revenue and your margin and remain solvent. But you also want to get there through cost containment, and that's clearly a priority of most C-suites. If you're the government, you want to reduce cost and manage and control. If you're an insurance company, you want lower costs, you want reduced payments to providers and hospitals so you can have a bigger profit. And if you're an implant company, you have a fiduciary responsibility to deliver a profit to your shareholders through quality and market share. So what about that definition of value? And this was what I learned from Regina Herzlinger and Michael Porter. Value is the outcome, according to the patient's experience, minus complications, divided by the cost to get there. And it says transparency here, but we're anything but transparent in cost in most hospitals. So what we also don't talk about is what's the value over time, because value is temporal. Who's going to capture all the value? Well, this depends in large measure on how you measure. Are you doing traditional cost accounting? Are you doing cost averaging? Are you doing time-determined activity-based costing? I don't have time to go into that, but these are very important because hospital systems tend to be anachronistic when it comes to the way they manage their cost accounting. So what can we say might be attractive to industry, to surgeons, and also to patients? Well, we want shorter learning curves, so we have fewer complications while surgeons are learning to do things better. We want reduced errors in planning because oftentimes the problem is wrong at the beginning. The problem is the wrong plan at the beginning. We want to reduce errors in execution during surgery. Can we engineer error avoidance? And a lot of technology will do this. We want to improve constructs for better biomechanics so we have more durability. We want an improved patient experience. And of course, we want lower cost if that's possible. So let's look at this curve, which demonstrates primary total shoulder and reverse total shoulder and revision reverse shoulder. If you look at this curve, the 90-day period is basically the time period by which value is delivered from the standpoint of the surgeon in the hospital. This is the period during which we are responsible for a payment for care. But after this period, if that care results in a durable outcome, the patient captures all the value. And if we introduce new technology that's more expensive, it affects the bottom line, in some cases, the hospital, in some cases, the surgeon, because of the cost of that technology. That's a dilemma. Because if we know that, for example, cross-linked polyethylene costs more but gives a more durable outcome to the patient, at least initially before the price came down, we had to wrestle with the question of it being more expensive. Now, Christensen and colleagues wrote in their book, The Innovator's DNA, we know very little about why one person is more creative than another. And I lifted this graphic here off of the internet from something I Googled that came up with the 12 greatest innovators of all time. And if you look at this list, you probably won't be surprised to see some of these names. But you have to go all the way down to number 9 in Marie Curie to see somebody who influenced healthcare. And I wonder how many of you understand, you know that she had to do with the use of radioactivity and imaging. But I wonder how many of you know that she was the first woman to win a Nobel Prize, but not once, but twice. Also, if we look at top medical advances in history, I wonder how many know that vaccines started in the 1700s. Anesthetics, of course, had their birth in the 1800s, and really the modern anesthetic era began with the ether dome at the Mass General Hospital. But we have to go all the way to number 10 to get to something that's really relevant and granular for us as orthopedic surgeons, and that's artificial intelligence. All these other things, to be sure, were transformational in healthcare. So back to Christensen. The question is, how do we identify people who have the potential to innovate? And I'm going to read a few things that comes out of his book. One, each year, 50 million new businesses start. Innovation is the lifeblood of a global economy. And so what he did in his analysis of who innovates and where they are, he looked at 2,500 innovators and 15,000 executives in 75 countries to see what characteristics these individuals had as innovators. And part of this is their aspirations. So look at what Steve Jobs said, and look at what Jeff Bezos said, and look at what Elon Musk said. One theme here is that this is not a genetic trait, but it's modifiable in terms of behaviors. So nurture trumps nature. And there are 5 key behaviors, and I'll go through them all because you may feel a little bit like you have some of these behaviors already, but if you cultivate the other ones, you'll be much better at innovating. Number 1 is questioning at a level to puncture the status quo. That means you have to be somewhat cynical about what you're learning and understand that much of it is incorrect. Second is observing. You have to be able to take time to be intense in observing. And it's very difficult when we're very busy running from case to case and seeing a lot of patients. We don't have time to free our mind to think. Networking. You have to create a diverse network of connections for individuals who will influence you in your thinking. You don't do this alone. Experimenting. You have to have the courage to experiment to some degree. And that can be very difficult if you're working in a risk-averse environment where experimenting is not really supported so much in a clinical setting. And you have to, most importantly, do associational thinking by linking ideas that are not directly related. So let's consider this a little bit more. If we look at questioning and observing and networking and experimenting, these create triggered associational thinking that can result in new businesses, new products, new services, and new processes. This is right out of Christensen's book. So let me pivot for a moment and talk about the Stanford Center for Biodesign. Thomas Krummel wrote an article in the Journal of Pediatric Surgery, which someone recommended for me that I otherwise wouldn't have seen. There are more details on this on the Codman Shoulder Society, and this is the link to get to that. And you can find that in my blog on Codman Shoulder Society. But let me quote a few things he said. He said, first of all, a scientist seeks understanding, an inventor seeks a solution, an innovator seeks an application. He went on to say an entrepreneur seeks independence, autonomy, and control to maximize the likelihood of success in a risky, defined, and uncertain, ill-defined venture. That sounds a lot like a surgeon. Furthermore, he said surgeons ignore technological advancement at their own peril. It can be difficult to get new technology into our medical centers, and that is a problem if you want to try to innovate new care for patients. Regina Herzinger wrote this wonderful article entitled Innovating in Healthcare, and it's a framework for that innovation in healthcare. And you'll again find this article on the Codman Shoulder Society if you want more information. She said, innovation, nothing new here, is 5% inspiration and 95% perspiration. But most importantly, she said to be successful in innovation has to be profitable, reduce costs, and have advocates. And there are 6 factors that affect any new healthcare venture. First of all, structure. You succeed or fail based on who is a friend, an ally, and who is a foe. Resistors can kill any innovation. Public policy. Does where you're trying to innovate and the regulatory environment, locally, nationally, institutionally, provide the rules and climate to allow you to innovate? How about who's paying for it? Financing is critical. How about technology? Most of us have technology now, and that's not so much a barrier. How about who's the focus? Who's the customer? Is it the patient? Is it the insurer? Is it the government? And what about accountability? To what degree is alignment and transparency part of this process? Christensen will disruptive innovation cure healthcare? And some examples include low-intensity portable X-ray machines, which cost 10% of large machines, physician-owned hospitals, which are more cost-effective than major academic medical centers and non-academic medical centers, cheaper, more simple, effective alternatives in general. Academic medical centers tend to use expensive technology that can't run efficient, lean businesses, whereas outpatient surgery centers, specialty care facilities are more cost effective. And we know this now, even in academic medical centers, though they were late to the game. The fascinating thing is that the regulatory environment blocked many of these, like physician-owned hospitals. Those were blocked around as part of the component of Obamacare. The other thing that's kind of interesting and problematic is that instead of working to enable those of us who have advanced training to do what we were trained to do from the standpoint of complex problems, dealing with complex problems, we're forced down market to do simple things like document in Epic, care complexity and charges and things of that nature. That takes away from our time doing what we were trained to do, and that is in and of itself a barrier to innovation. Now, for sure, in 1998 and certainly now, academic medical centers have higher average costs, and in fact, where you work affects your ability to deliver value, principally because of this strain on your bottom line, but also because of the culture it creates from the standpoint of priorities, much of the time, economic. Derek Haas and Michael Jelnick and Robert Kaplan, all from Harvard Business School and from our medical system, wrote about hospital budget systems and why they're a problem with innovation. For example, in their article, they stated 800 digital health startups were funded in 2017, while 75% of senior hospital executives endorsed digital innovation. Hospitals were notoriously slow to adopt these innovations. And the reason was a variety of barriers, but they were part of the structure of the organizations and the culture. Unaligned budget units, rigid annual budget, operating budgets, and separate budgets, timelines, and processes. So if I said before that associational thinking is one of the most important things, try to do a complex study that involves multiple departments, and you're going to run up against who's going to fund this endeavor. That's a big problem. Well, it was Einstein who said that imagination is more important than knowledge. But do we have the opportunity to imagine things and then to make them happen? So how do we innovate value in our own environments? Let's consider for a minute the professional and personal barriers of being an innovator. In many institutions, you need to be a square peg in a square hole or some other shape because fit is critically important. And this is like many medical centers. But many innovators are like this, and it's not by accident that they're disruptive and considered to be problematic because they don't fit into a particular hole, and they also don't fit into the cultures where they find themselves working. Actually, 100 years ago, Codman looked at this, and in his epilogue, which is a fantastic read in his book on the shoulder, he wrote about financial health and its effect on your ability to be innovative. And if you see this pyramid that's upside down, this reflects priority in times of plenty. And at the top of the pyramid, the patient was the first priority because his economics and his ego were at the bottom because he was doing very well from the standpoint of all of these things. He was comfortable in his job and comfortable in his life in terms of economics. But later on in his life, when priorities were not as good, the pyramid flipped the other way. And his needs, not just his ego, but his financial needs, became a priority that took precedent over his patients as a priority. Why is this relevant to us? Because compensation plans matter. You know, how much time you spend earning an income to support your family and to support your time to take away and do research does run up against your time freedom to be an innovator and think. This is fascinating because if you look at the Journal of Management, this is a study done in a collaboration between the London School of Business and the London School of Economics, looking at soft and hard models of human resource management. What do I mean by that? Effectively, we're talking about culture. So in companies that are for profit, like Google, Netflix, and a variety of others, these tend to be soft models where innovation is scaled from the bottom up. In hard models, like large academic medical centers that are very much structured in a way that have to be fiscally responsible, it's largely a top-down approach. And this certainly affects the ability to innovate. In fact, Harvard Business School professors did a study on culture and performance. And when they looked at weak versus strong culture, just look at the metrics here for financial success in terms of revenue and workforce and stock prices and net income boost between the two. Stronger cultures always win. I don't mean to suggest that where you may be working is a weak culture. I'm just saying that we have to contrast where you work to others. And I'll show you what I mean in a moment in terms of some economics. Well, this is Scott's parabola, and it can be applied to a variety of things, but generally it's applied to the diffusion of innovation. So where we work matters. If you look at the different color schemes here, private groups, privatedemic, that means private groups that do academic things, formal academic programs, and academic universities, who are the innovators? Innovators, I believe, tend to come from the perimeter of the academic world. I'll show you why I think this is the case. Then you have early adopters who are also more or less in that group. Then you have privatedemic groups. And frankly, the large academic medical centers are understandably late adopters or laggards. And the reason is they are risk averse because of what they have to do in terms of quality and safety and managing their patients. It's also their culture, however. Now, this is a very interesting article in Health Affairs Scholar entitled, Why is it so hard for academic medical centers to succeed in value-based care? So let me read some of the article to you. Academic medical centers excel in many ways, but struggle to succeed at delivering cost-effective care in value-based payment models. Much of the underperformance of AMCs is due to two core competencies they lack. Number one, limited ability to redesign their clinical workflows, which are rather complex in these centers that have multiple commitments and missions. And number two, inability or perhaps an unwillingness to change their economic relationships with their own specialists. A variety of key factors here include electronic medical records, compensation systems that reward volume over value, the organizational structure that may be problematic to change management or perhaps innovation, and complex and poor accounting systems. Really, they're anachronistic in some ways. We all know that there are promising technologies that were a bust. So when you look at this promising idea and the enthusiasm for its adoption, especially in orthopedics, we're rather naive. Arthroscopic thermal shrinkage, metal-on-metal hips, BIOX, intra-articular pain pumps, all of these rose and fell based on initial enthusiasm and an unwillingness to wait for evidence, and then realizing that these were problematic. So if you want to be an innovator, or let's say even an entrepreneur, and that includes any kind of innovation, be it care innovation, new processes in your organization, this is the route you go. You always go down before you go up. So when you have an idea, you'll always have resistance. You'll have problems with funding, and that may be endorsement of the people that you have to manage up to. You may be ridiculed, and many of the innovators I'm going to show you in a moment have all gone through this. You'll despair in the process and want to abandon your efforts. Then you may have some validation, which encourages you. Then maybe you'll get more support, in this case, perhaps funding. And eventually, you'll become profitable and survive and scale. And it's not necessarily money I'm talking about. It may also be changing care delivery processes. It's difficult. It's a hurdle race, not a race. This is from a presentation I gave about my experience in learning at Harvard Business School. And most people think that success is a straight line. But as this talk is meandering a bit, that's the same journey that you take as an innovator or an entrepreneur. It's not a straight line. So I thought about this a lot. And the Codman Shoulder Society is a group of experts that like to get together to think about things and collaborate as a group. It was Codman who 100 years ago said, give me something that's different for there's a chance of it being better. And in that regard, he was a true entrepreneur. Ozan Varal wrote a book entitled Think Like a Rocket Scientist. He was a NASA scientist, and it's very important to understand that we're all affected by bias. He said our tendency towards skewed judgment partially results from the confirmation bias that we have. We undervalue evidence that contradicts what we believe, and we overvalue evidence that confirms it. And this is not what happens at NASA. NASA's always questioning what they're doing. Well, I asked the members of the Codman Shoulder Society to list for me the major innovations over the last half century in orthopedics, and in particular, really in shoulder surgery. And it's not surprising if you look here that reverse shoulder prosthesis is number one. And this was published in Rockwood and Matson's book, and I'll eventually put it on the Codman website because right now you can only find it in a chapter form. Look at some of these other technologies. Anchor technologies was number two. Arthroscopic soft tissue repair, and go down the list. Most of you who are young will take these for granted. And in fact, Christian Gerber said that's exactly what happens. Innovations that change things are ultimately taken for granted. We take for granted CT scans and MRIs. And now reverse replacement, which was revolutionary and transformational at the time, is growing at almost 2 to 3x conventional shoulder arthroplasty. So back to Scott's parabola. How does a technology scale? Perfect example is what the members of the Codman Shoulder Society picked as the number one innovation, which was reverse replacement. Now, here's Paul Grammont, who followed that trend that I showed you of the despair and then the elevation of an innovator and an entrepreneur, but he was more of an innovator than an entrepreneur. I submit here that because of early adopters and innovators, and I'll show you who they were, Paul Grammont's idea was scaled. And it survived because it made an enormous difference in both value, in both outcome and cost, so it increased value. But some academic medical centers live to the right on this curve, and it takes a while for them to adopt these technologies. Christian Gerber also gave me this curve, which is very important. If health is on the vertical and cost is on the horizontal, then really innovating value is a steep part of the curve. Unfortunately, much of what we see now coming from industry, and actually in articles that we read, are effectively derivative innovation. They're rehashing of what we already know with incremental increase in actual health or improvement of care, but with added costs. And so cost-saving technologies and knowledge can also follow this curve. So technology adoption, that is the life cycle of a product or an idea, follows this route. You have the innovators, and then you have the early adopters who want novel things, but you never get to the mainstream unless the process or the product is easier to adopt. It doesn't require major process changes, certainly lower cost, and thus a higher value. How many of the things that we use every day that we want to use to improve our care fulfill this criteria for scaling? Well, let's consider some examples of people who did this. I think everyone would agree that Sir John Charnley, who created the first modern total hip arthroplasty, changed the paradigm of care. But I wonder if you knew that William Harris, who basically had a lab that created highly crossing polyethylene, was in private practice and not with an academic appointment as a full-time practicing physician at a major academic medical center. In fact, he and his colleague Arhun Matoglu wrote this great article demonstrating the durable value and cost reduction because of the effect of crossing polyethylene reducing revision surgery. Remember that graph I showed about the temporality of value? Well, that's a perfect example here. But there was significant resistance because of cost in some centers, because it cost, of course, it cost more to make this, and it cost more to get it into the market to begin with. It was Reinhold Gans who effectively invented the entire area of hip preservation when he discovered or created femoroacetabular impingement as a diagnosis, and then approached this with periacetabular osteotomies, which subsequently have moved on to treatment through arthroscopic management. Now, when he did this, it was towards the end of his career. He had no grants. He didn't really have the title he had to begin with, and he had no research lab. It was all creativity happening in his mind. Back to Paul Grammont. Paul Grammont was ridiculed for his ideas of reverse replacement, and many had come before him trying to do the same thing and failed miserably. Why is it the case that he would follow, and why was he so successful when so many others had failed? So if we look at surgeons like him, like Neer, like Codman, these are some of the things that they did that distinguished them as innovators. Every single one of these individuals had failures for sure. In fact, Neer was wrong when it came to the genesis of rotator cuff tears being impingement, and certainly he was wrong with the spica that I had to wear. And Codman wound up buried in an unmarked grave in Mount Auburn Cemetery as he was a pauper after he was fired from the Mass General Hospital and failed in his endeavor to create his own hospital. But not all innovation is an implant. And back when these individuals were innovating, the regulatory environments were less severe than they are now, and there actually were somewhat less barriers in the hospitals, although there was still the kind of resistance to innovation. In fact, it wasn't their DNA, it was their behavior and the willingness they had to do all the things I just mentioned previously in terms of what Christensen said are the 5 behaviors necessary to be an innovator. Now, the Meyer Award was created by Christian Gerber to honor his former partner and would-be successor, Dominic Meyer, who unfortunately passed because of an untimely illness when he was a young man. And the first winner of this award, which has been called by some the Nobel of Orthopedics, was given to Reinhold Gans, and I was one of the judges in the first 2 awards that was given. I want you to note here what Gans used as his title, Hip Preservation Surgery, Breaking the Rules. In fact, he said in his lecture, innovation is barely possible without breaking the rules. Curiosity and lateral thinking are more helpful than follow-up studies and meta-analyses, and teamwork is indispensable to get going a project and bring it to maturity. I was privileged to work with extremely motivated teams. This is a team process, and it requires that you suspend the status quo and find a place where you can do that. And fortunately, he was able to do exactly that. The reverse idea came to us from Europe after more than a decade of experience. And by the time it came to us, and Paul Grammont, shown here was Gilles Walsh, one of the early adopters and innovators that followed him, Paul Grammont had had a stroke and was aphasic before this scaled in the United States. And his contribution is a legacy, to be sure, for everyone who has rotator cuff tear arthropathy or other conditions that are untreatable with other methods. Because of people like Gilles Walsh and Christian Gerber and Pascal Boileau and Mark Frankel, this has scaled so much. So it's not just the idea you have, but the people that scale your idea and the network you have in creating this opportunity. Innovators who have changed treatment paradigms are shown here. I've already talked about some of them, but I'll add in Misaki Watanabe for arthroscopic surgery, or Christian Gerber for all of the clinical contributions he made to help us understand the different conditions of the shoulder and how they can be treated with novel procedures such as tendon transfers. I wonder how many of you know Lanny Johnson, who now in his 80s is still an innovator and not only has multiple patents, he effectively created the arthroscopic shaver. Charles Neer, of course, Richard Kaspari, who created the foundation for much of what we do in arthroscopy. And I wonder how many of you know that Ray Thal, an individual who's in private practice in Reston, Virginia, created the first knotless anchor, which you now take for granted. And for a number of companies provide these sorts of technology. It started with Ray, who wasn't an academician. I won't go into more detail, but Gilles Walsh and Pascal Boileau, and of course, Joe Ionati, who really started the ball rolling when it came to digital planning tools as a basis for improving what we do in arthroplasty. So many more. Even in arthroscopy, dexterity, technology, conviction. Lanny Johnson shown here. Arvid Ellman, who you probably may not know, was the first person to create arthroscopic subacromial decompression. Gary Gartzman, Jim Esch in education. Steve Snyder shown here. Steve Burkhart, Kaspari. Laurent Lafosse, who effectively created a variety of procedures that have changed what we do, including arthroscopic latarjet, but all sorts of arthroscopic nerve surgery. So what's in a network? This is also a part of what I've been lucky enough to create for myself and for others. A network is really important to what you do, and it isn't about the number of people you meet, but it's the number of people you introduce others to. It's kind of like the power of compounding interest. These individuals are available to you to help you solve problems and to give you insights you otherwise wouldn't be able to have, and you likely as well for them. Innovators are an interesting group. They grow together, compete with one another, and learn from one another. Look at this image of these young individuals here. Behind the tree here is Christian Gerber. You can see Gilles Walsh in the yellow sweater, next to him Pascal Boileau, and many who you may not know, like Goutallier, who created our understanding, or basically was the first to create the understanding of fatty muscle atrophy and rotator cuff tears. Following the Sixth Congress of the International Shoulder and Elbow Society held in Helsinki, Stockholm, these individuals went to the towards the northern part of Finland and met together to discuss many of these questions. Look here at this group here. This was the advanced shoulder arthroscopy course, and this is one of the reasons innovators get together with one another, whether it's at these meetings or other meetings. They're willing to travel to meet other like-minded individuals to help them think about things and innovate. Here's Evan Flato, here's Gilles Walsh, a young Gilles Walsh, a young Christian Gerber. You see Bassem Elissan here before he became the Bassem you now know, when he was 1 year after my fellowship, myself, Buddy Savoie, and John Ticker. Now let's come back to some culture things. Large organizations versus smaller organizations. Larger organizations, understandably, have top-down management teams that are selected based on their delivery skills and not their disruptive skills. They're established firms that do well with incremental innovations. Again, this is from Clayton Christensen, whereas smaller organizations tend to select leaders based on their disruptive skills and their ability to know how to think differently, and they do better with more radical changes. This is really the basis for startups being acquired by larger organizations. Again, it was Michael Porter said the essence of strategy is choosing what not to do. So what will you do and what won't you do if you want to innovate? So let me share with you a few innovations that I've chosen to do, and these are not revenue generating products. I took to heart thinking about a roadmap to differentiate what I did as a practicing orthopedic surgeon and in particular shoulder specialist. So in 2014, I established the Boston Shoulder Institute on my own. And it's not a revenue generating entity. It's a patient educational portal of sorts within the Mass General Hospital. I decided to make it about the patient, the principal customer, and clearly state a value proposition. And so our value commitment is here: communication, access, accountability, transparency, care coordination, and critical introspection. It turned out that this was a quite compelling business approach. So this is what Herzinger would have called a consumer innovation, and it was based on measurement. Ask yourself what the patients want. What they really want is confidence and reassurance. And through transparency, that's exactly what you deliver. So you can see here one of our approaches is quality metrics. And every year, we review all our cases. We study the process of recovery of our patients. You can see here our quality reports. You can see our annual reporting of our quality. This includes all complications. So we are able to then analyze these and tell patients the risk-benefit analysis for what they'll undertake. We can present this in graphic form. We can present it in list form, as you see here with the complications 1 year. We can look at the individual complications. So this particular year, 3 cases, 0.7%, had to be readmitted for management after surgery. We can do cohort analyses because of these, and that includes patient-reported outcomes as well as a registry of sorts. We can look at patient satisfaction, like in this cohort of 196 patients after shoulder arthroplasty. We can look at why patients are unhappy to see patterns of unhappiness, and eventually AI is going to help us identify certain patient characteristics that are likely to lead to less happy patients. We can look at patient expectations, including whether or not they think the care that they had exceeded their expectations or met their expectations, as a basis for knowing how patients are going to do. And here's another example here with reverse replacement, for example. And in addition to the complications that we analyze, we can look at large data sets, and we've since looked at much larger number than this, but you can see for 430 cases, our infection rate was 0.25% for total shoulder and reverse replacement, that is primary surgery. And now that number is well over 800 with the exact same risk of infection. Larry Higgins and I wrote, with the aid of Michael Porter, this editorial article in the Arthroscopy Journal entitled Volume and Outcome, 100 Years of Perspective of Value from E.A. Codman to Michael Porter. And again, the theme here is when we measure, we improve. Actually, Michael Porter allowed me to use this graphic that he created entitled The Virtuous Circle of Value. And it was Bob Kaplan who said, if you can't measure it, you can't manage it. And if you can't manage it, you can't improve it. So if you look at this strategy, your reputation will improve as you get better results. And this will be a virtuous circle of value to improve your patient's outcomes and your efficiency. And in fact, you benefit from becoming an expert and providing better care. This gives you a competitive advantage. It improves outcomes and it reduces costs, and it's a form of innovation. I'll come back to this in a minute to prove that they're absolutely on target. So if we go back and look at Codman 100 years ago, these boxes are full of his so-called end result cards. Before the digital age, he kept track of every patient with cards. So why don't we measure outcomes just like he did 100 years ago? Not only did he measure outcomes, he measured costs. So when you look at the denominator here, he identified that if a surgery succeeds versus fails, the cost is lower and thus the value is higher for the patient. Again, he not only was an innovator, he said that measuring the end result was paramount. And so the Codman Shoulder Society is also a group committed to recording the end result for every patient, determining the best practices and optimizing outcomes in shoulder care, just as Codman envisioned. Now, while I do it, unfortunately, I don't know that everybody does it, but many of the people who partner in Codman Shoulder Society, or at least visit, have the same philosophy. So a little more about Codman Shoulder Society. If you are interested to join, all you need to do is email me. You can also message me in LinkedIn. This is one of our meetings. You can see here Christian Gerber and Gilles Voss talking about innovation. Here's another meeting where Bob Kaplan talked about measuring to deliver value. These are some of the posts I have here that may be relevant to you in terms of your career development, in terms of issues of innovation and managing yourself in difficult circumstances, which I think are part of innovation, etc. And all I do is I curate from all the noise the things that I think my colleagues will find of value that may help them be better innovators. This is our group in 2019 when Bob Kaplan visited us. This was our group, and this occurred at the San Diego Shoulder Institute in 2022 when we looked at the value of digital technology. Here's in 2023, we looked at innovators, entrepreneurs, behaviors, and culture. And you can find all of these on the Codman Shoulder Society with videos of all of these presentations, both on ViewMedi as well as on YouTube, with summaries of these presentations as well. Our last meeting, and going forward, mostly all of our meetings are going to be webinars, dealt with value in orthopedics, and in particular, we looked at hospital-physician collaboration from a financial point of view in terms of cost management. Our keynote speaker was Susanna Galani, who talked about how to think about physician-hospital alignment and compensation. And she stated the construction of your compensation plan is the strongest signal you can provide about the priorities of your entity. Remember what I said about Codman and what his life was like relative to the good times and the bad times? We also created a multi-center research group as a collaboration with Avant-Garde Health, which is an outgrowth of Harvard Business School. And this is a healthcare data analytics company that you should really check out because they're quite remarkable. And the value that they create for the organizations with whom they work is really fantastic. So this is an example of some of the work we did. This is an article, the lead authors of which were Matthew Best and Catherine Fedorka, two individuals who were my former fellows, and many of the other former fellows are here, as well as those who wanted to be part of this. This is our multi-center research group. And we looked at 151,000 shoulder arthroplasty cases and looked at the factors affecting risk of complication and in particular revision surgery. And you can see the conclusion here about volume. So look at this graph for a minute and realize on the far left, it is the case that 50% of all surgeons do low volume surgery. Whereas on the right side, those who are experts constitute only 5% of the surgeons, and yet they're doing 38% of the episodes of care. There's a problem here because complications are directly correlated to this, and some of this is also a learning curve issue. Look at the revision rate here when you go from low volume to high volume. Doesn't seem like a lot, but it's really many, many cases. And the revision rate for anatomical and reverse replacement, and a scatter plot demonstrating this trend, and then a summary. So if an individual does greater than 10 anatomical total shoulder arthroplasties per year compared to the low volume surgeon, there's a 27% reduction in the risk of revision surgery over 2 years. And if it's 29 cases or more, it's a 33% reduction for anatomical replacement. And in reverse replacement, it's a 26% reduction. So by becoming an expert, you become a greater value, a greater caregiver for your patients. We also looked at machine learning, and here's one of the other articles we published, and there are many more. They're all available on Codman Shoulder Society. I'm only briefly going to comment here. Many of you may use the Spider device. It was my privilege to help design that. Many of you use ViewMedi. I've been involved in that. Orthospace is a recent development that came to the market. And then, of course, Blueprint, which you may be familiar with, which was one of the first of many now digital tools to allow us to plan surgery so we don't make errors in the operating room, we make them virtually. So I'm going to finish up in a little bit with context. And let's think about the places we work from the standpoint of motivation by a carrot or a stick. It was Peter Drucker, the great management guru, who said, culture eats strategy for breakfast. But I wonder how many of you know who said, you're either at the table or on the menu. And that was the gangster Al Capone. So recently, in the webinar I showed you, we looked at surgeon-related drivers of hospital costs. We also had a symposium at the Academy on this. And this was published already and was a collaboration of many. Evan O'Donnell was a principal author here. David Bernstein was also a principal author. And we looked at over 700 arthroscopic rotator cuff repairs performed by 13 shoulder and sports medicine fellowship-trained physicians at our 2 academic medical centers. And we used cost accounting methodology called time-determined activity-based costing. And what did we find? We found that for CPT code 29827, which is arthroscopic cuff repair, costs varied by 6x. Intraoperative costs were about 91% of the entire episode of care. That's pre-op to intra-op to post-op. The major cost drivers were biological adjuncts, like grafts and things of that nature, and the surgeon idiosyncratic decision-making that had to do with which anchors they used, how many anchors they used, etc. Additional cost drivers were tendon retraction and fatty atrophy and number of anchors used, but less impactful than the ones I've just indicated. And not associated with major costs were age and comorbidity and the number of tendons torn or even revision surgery. This is a method to look at this. This is sort of a target graph demonstrating total episode of cost of care. And in the inner circle, you see normalized cost per patient, those that are likely to be margin positive. And you can see the outliers here that are likely to be high cost and most likely margin negative. That's interesting because that's a value we can provide to our hospitals if we're able to help them in managing their costs and thus their profitability. And at least at the academic medical center that I know, most programs are margin negative, and funds flow from the hospital are essential to maintain the vitality of the department because the costs of running the department are higher than the actual cash generated to the department. So I promised we'd look at some of the finances here. And so let's look at a variety of systems and consider this. My own institution, this is public data, Mass General, in 2022 had a negative margin of 1.7%. And then in 2023, they were a little more successful with a 0.5% margin. And now it's a 0.1% operating margin. And look here, Tenet Healthcare is the highest with 21 billion in operating revenue and a margin of 14.6%. And Kaiser Permanente has $100 billion operating revenue with an operating margin of 3.4%. And then, of course, Mass General is down below, and you can see UPMC, where I recently visited, is negative now. It's very difficult to understand how those in the negative or close to the negative can afford to take the time to be creative based on the cultural issues that I've mentioned. I went ahead and did some additional studies. This was when I was at Harvard Business School. This is a separate study that we did, but each of the letters on the left side is a physician. Would it surprise you to see that for a straightforward ACL surgery, the variation among providers was 2.3x? So even in an operation done routinely, there's a significant variation in cost. And again, for rotator cuff surgery, looking at all the providers here, again, in letters you see, yellow are the most expensive and green is the least expensive. You can see about an 8x variation in cost. So it was Einstein who said genius abhors consensus because when consensus is reached, thinking stops. So stop nodding your head, or perhaps after this talk, you're nodding out because it's such a long talk. And I would encourage you to think about these things in the context of where you work and then imagine how you can improve your environment, because I personally believe that innovation is the antidote to burnout. So those who are interested, these are the websites that I believe have been innovations: the Boston Shoulder Institute, the Codman Shoulder Society. I'd mentioned to everybody that the 42nd annual shoulder course of the San Diego Shoulder Institute is June 11th through 13th in 2025, and we are the oldest shoulder meeting in the world. It'll be held at the beautiful Del Coronado Hotel, and I welcome everyone there. Thanks for taking your time, and I hope this was of value for you. Bye-bye.